Hello everyone, welcome. In this lecture, I'll talk about the control of breathing. So the control of breathing actually is mainly coordinated in the brainstem. So the brainstem actually gets the sensory information from the central and peripheral sensory organs and then controls the respiratory muscles and the breathing cycle. So this is the main seat of control. And in the brainstem, especially in the reticular formation, you have the medullary respiratory center. And the medullary respiratory center has two groups of organs. One is the dorsal respiratory group and another one is the ventral respiratory group. Dorsal respiratory group is actually more important, which actually controls the inspiration and regulates the basic rhythm of the respiration. And the input to the dorsal respiratory group comes from the vagus nerve and the glossopharyngeal nerve. The vagus nerve carries the input from the peripheral chemoreceptors and also the mechanoreceptors in the lung. The glossopharyngeal nerve carries the input from the peripheral chemoreceptors only. And the output from dorsal respiratory group is through phrenic nerve, which contracts the diaphragm and controls the inspiration. The ventral respiratory group is actually mainly responsible for forceful expiration. So during normal quiet breathing, they are not activated. But when someone is exercising and expiration becomes an active process, the dorsal ventral medullary respiratory group is activated. Now let's talk about the apneustic and the pneumotaxic center. So both of them are located in the pons. The apneustic center is located in the lower pons and the pneumotaxic center is located in the upper pons. The main job of apneustic center is to stimulate inspiration, and this is a different type of inspiration where it produces a deep and prolonged inspiratory gasp, also known as apneusis. The pneumotaxic center is an inhibitor of inspiration, so it actually regulates the inspiratory volume and the respiratory rate. You can remember that pneumotaxic, you can write it by pneumotoxic, so it's toxic to inspiration or toxic to lungs, so it's actually inhibitory to lungs. Cerebral cortex can sometimes also control the respiration, which is called voluntary control. So a person can voluntarily hyperventilate or hypoventilate, and hypoventilation or breath holding is actually limited by the resulting increase in partial pressure of carbon dioxide in the blood and decrease in partial pressure of oxygen, which both of them which stimulates the peripheral and central chemoreceptors, leading to an respiration. And a previous period of hyperventilation can actually extend the period of breath holding. So this now comes the most important regulators of breathing cycle. So those are carbon dioxide, hydrogen and oxygen. Those three are the most important factors that regulates the respiratory rate. So let's first talk about the central chemoreceptors, which are situated in the medulla. So in the medulla, the central chemoreceptors are actually sensitive to the pH of the cerebrospinal fluid. If the pH of the cerebrospinal fluid decreases, it produces an increase in breathing rate or hyperventilation. But the hydrogen, as it is an ion, it does not cross the blood-brain barrier. But carbon dioxide can cross the blood-brain barrier. So whenever carbon dioxide is increased or hypercapnia occurs in your blood, it diffuses from the arterial blood to CSF because it has a high lipid solubility. And in the CSF, the carbon dioxide combines with water to produce hydrogen ion. And this hydrogen ion reduces the pH, which acts directly on the central chemoreceptors. So increases in partial pressure of carbon dioxide, resulting in increase in hydrogen ion concentration in the central chemoreceptor, stimulate breathing, and vice versa. Now let's talk about the peripheral chemoreceptors in the carotid and aortic bodies. So carotid bodies are actually situated in the bifurcation of the common carotid arteries, and the aortic bodies are situated above and below the aortic arch. If there is a decrease in arterial partial pressure of oxygen, it will stimulate both the peripheral chemoreceptors. So the peripheral chemoreceptors will be stimulated and it will lead to an increased breathing rate. And PO2 or partial pressure of oxygen actually must decrease to low levels, less than 60 mm mercury, to stimulate those chemoreceptors. And peripheral chemoreceptors in carotid and aortic bodies can also be stimulated by the arterial partial pressure of oxygen, partial pressure of carbon dioxide. So if there is an increase in partial pressure of carbon dioxide, it will stimulate the chemoreceptors and increase the breathing rate. But the peripheral action of arterial PCO2 is actually less important, and the central action of the partial pressure of carbon dioxide is more important. Increases in arterial hydrogen ion concentration can also stimulate the carotid body, and it can lead to increase in breathing rate. It occurs in case of metabolic alkalosis. So in case of metabolic alkalosis, the hydrogen ion concentration is increased, which leads to increased breathing rate due to stimulation of the peripheral chemoreceptors, leading to hyperventilation. And this is known as Kussmaul breathing in case of diabetic ketoacidosis. So here I have shown you some contrast between the central and the peripheral chemoreceptors. So the central chemoreceptors are actually situated in the medulla, and the most important stimulator of the central chemoreceptor is increased partial pressure of carbon dioxide indirectly, which causes increase in hydrogen ion, leading to a drop in pH, so which ultimately stimulates the medullary respiratory center. The peripheral chemoreceptors are located in the carotid and aortic bodies, and the most important stimulators are low partial pressure of oxygen, especially if the pressure is lower than 60 millimeters of mercury, and to some extent increased partial pressure of carbon dioxide and decreased pH also stimulates the carotid and aortic bodies. There are some other types of receptors for control of breathing, which are lung stress receptor, irritant receptor, juxtacapillary receptor, joint and muscle receptor. So the lung stress receptor actually are situated in the smooth muscles of the airways. So if there is increased stretch of those smooth muscles, there will be a reflex decrease in breathing frequency. This is called the Herring-Brewer reflex. The irritant receptors are situated in the airway epithelial cell, in between the airway epithelial cells, and they are stimulated by noxious substances like dust and pollen. The juxtacapillary receptors are situated in the alveolar walls close to capillary. That's why they are called juxtacapillary. And engorgement of the capillaries, like in left heart failure, will stimulate the J receptors, stimulating rapid, shallow breathing. The joint and muscle receptors are activated during movement of the limbs, and those are involved in the early stimulation of breathing during exercise. So here we have a practice problem. A 56-year-old heavy smoker presents to your office complaining of a chronic cough and a lower extremity edema. Physical examination reveals significant cyanosis and expiratory wheezes scattered toward the lung fields. Shortly after given supplemental oxygen through a nasal cannula, the patient's respiratory rate decreases and he becomes increasingly confused. This clinical decline is the result of decreased stimulation of which of the following? So pause for a moment, pick your answer. So here my answer is decreased stimulation of the carotid bodies. So why is so? First of all, look at the case. You have an older patient who have a history of smoking, history of chronic cough, and lower extremity edema. So those points should suggest you that this patient might have chronic bronchitis along with carpulmonal. And also, as you can see, the patient has significant cyanosis and expiratory wheezes, which also proves the fact. So this patient have a diagnosis of chronic bronchitis with carpulmonal. And in case of chronic bronchitis, there is persistent hypercapnia. So persistent hypercapnia actually leads to a decreased sensitivity of the central chemoreceptors to the changes in carbon dioxide concentration. So the main driving force of respiration is the peripheral chemoreceptors, which are actually acting, or which are actually sending the stimulus due to a low partial pressure of oxygen. So whenever this kind of patients are given high level of supplemental oxygen, this reduces the action of the peripheral chemoreceptors. So the input from the peripheral chemoreceptors are decreased, so the frequency of breathing is also decreased. So the respiratory rate decrease, and it causes an even more decrease in oxygen level. So it causes confusion due to hypoxemia. So there is actually decreased stimulation of the carotid bodies. So that's all from me here today. Thanks all for watching my video.